Okay, right. Well, good evening, everybody. Thank you for joining us this evening for the next in the series of Jewish Medical Association webinars on the subject of COVID-19 and experiences and expectations. And this is the first time we've had somebody from out of the UK. We're very honored that we've got somebody from Israel and somebody who has played such an important role in both in Israeli medicine in general and in the role of women in medicine in Israel and in the School of Public Health. And Ora Paltiel was the director of the School of Public Health, and many of you probably heard her when she gave talks while she was on sabbatical in the UK about 18 months ago. The one issue that kept on cropping up in the feedback on previous events was the question, what is happening in other countries? What is happening in Israel? How do we compare with what's happening in Israel? And what are the issues that arise there that are similar or different to those that arise have arisen in the UK? And I don't think we can find anybody better qualified than Ora to actually tell us about the experiences of Israel in the last 4 or 5 months. Ora.
Thank you. Thank you very much, David. Can you all hear me? David, can you hear me?
I can hear you perfectly well, and I think everybody else can hear you. And we'll get Q&A and chat comments if they can't.
Okay, fine. So I'm very honored to speak with all of you, and I wish I could see you. And I would much rather be not having a virtual lecture with you, but actually be in London where we were a year ago and speaking to you from there. But I think Israel does have a few interesting anecdotes to recount in this COVID epidemic. Some of them are worthwhile learning from. Some of them are worthwhile not learning from. And I personally have been involved in the COVID epidemic from 3 points of view. The first is a project that I'm doing with 2 colleagues and a student on comparing policies in different countries. So I'm going to show you a little bit about that. The second is a clinical project looking at what happened to what we call collateral damage, what happened to time-sensitive acute conditions during the COVID crisis in Israel. And the third project is dealing with the role of children and school closures. So I'm going to try in the next 35 minutes or so to cover 2 topics, really what happened to Israel during this epidemic and what is the role of children in COVID in general and in Israel in particular. So first of all, looking at the COVID epidemic in Israel, if you had asked me to speak in May, that's what our epidemic curve looked like. It was very small, very cozy, very contained, and we almost got to containment. We got to 20 cases a day by the beginning of May, but the graph doesn't stop there, and this is what happened later on. So we are well into the second wave of the epidemic, and the second wave is different than the first. We have a lot more cases per day, but we have still maintained a relatively low mortality rate, which you'll see soon enough. And the spike happened relatively quickly. So if we compare the UK and Israel, and the top graph is confirmed cases per million. So we're controlling for the size of the population. So you see that in the UK, you had the steep epidemic curve, and there's a gradual decreasing or flattening, if you will, of the curve. Whereas in Israel, we had a steep rise, and then a very nice decrease, almost to zero. This is a log scale, so 1 case per million. And then this rapid increase again, with also an increase of testing that happened in June and July, and also an increase in the positivity rate. So for every 10 tests, say over 5 were positive in June and July compared to lower numbers earlier on. If we look at mortality comparing the UK to Israel, here again, the scale is extremely important. So first of all, the shape of the curve in the UK, I'm sure you're all familiar with, and somewhere above 600 deaths per million, whereas in Israel, we have a S-shaped curve. So we had a rise and then some kind of flattening and then this increase, but the scale is 10 times less, even more. So we're at about 50, 55 deaths per million. So in some ways similar, but in some ways very, very different epidemic curves and outcomes in our two countries. And all this is in countries where we have a socialized medicine or national health service of a sort. It's organized differently between the two countries, but we had some similarities in terms of the stresses in our public health system prior to the COVID-19 epidemic. And this just illustrates the number of beds per 1,000 population in Israel and the UK. And you can see similar decreases in the last 10 years, and both of us ending up with less than 3 beds per 1,000 acute care beds when we started this epidemic. So these stresses, I think, were very pertinent and relevant in the UK. In Israel, we never overwhelmed the hospital system because we just didn't have all that many hospitalized patients and intubated patients, but could have easily happened. Okay, so what about the measures to curb the epidemic? And this I'm sure you know better than I. Israel was quite quick at closing non-essential businesses. These are the OECD countries. And we can see that Israel was 5 days from 100 cases to closing businesses, where the UK was 15 days. And in terms of school closures, this is border closures. We know that we were very quick. I don't know why this says school. This is border closures. We were very quick, whereas the UK somewhere way down here in terms of closing its borders. Does this have any implications for the death rate? It probably does, and I'll show you that in a minute. So one of the things that you can be proud of is the kind of data that are coming out of the UK, and one of the sources is the Oxford Coronavirus Response Tracker, and they looked at over 100 countries, I think 160 countries. They had 100 students and faculty members looking at measures of curbing the epidemic, and they built a stringency index based on these factors: school closing, workplace closing, public events being canceled, restrictions on sizes of gatherings, et cetera, et cetera, et cetera. And if we look at Israel, which is the purple line here, we can see that Israel had pretty rapid stringency index and went very high, even higher than Italy, even though the morbidity from the virus was very low at that time, but I guess the fear factor was very high. So Italy had a lot of cases, Israel did not have a lot of cases, and despite that, we had a very high, almost 100% stringency index, meaning total lockdown and all of these other factors in place. What Thomas Pueyo in his famous article would have called the hammer. So the hammer came down very, very hard on Israelis very early on in the epidemic. And then after the hammer comes the dance, which is supposed to be how we choreograph the exit strategies. And for some reason in the Oxford corona response tracker, they stopped tracking Israel near the beginning of May. I don't know if they ran out of steam or they got fed up with us, because actually our dance was not very well choreographed. I would call it a trance and not really a dance. And it became quite chaotic. I'm not sure that's the reason that they stopped following us, but we can't get information from them. So we have to use other sources. So what about these measures? Do they make a difference? Well, this is some research that we've done. It's an ecological study, but we're just looking at days from 100 cases of COVID to border closure and its correlation with deaths per million. And you can see that Israel early on closed its borders very quickly and also had a very low mortality rate, whereas other countries took a long time closing borders and had much higher mortality rates. Same can be seen for closing non-essential businesses, but the curve is not so nice and neat as with border closures. Okay, what happened at the beginning of this epidemic, I'm sure you're all familiar, is that people used the paradigms that they already knew. And the most famous paradigm was pandemic flu. And that is the reason, I think, why schools were closed all over the world. This is one of the things that kind of bothered me as an epidemiologist early on. Why is the flu, despite the fact that it's a respiratory infection, why is it being used as the model for predicting this disease and for telling us what we should do to curb this disease? And I don't have to remind you that the Imperial College predictions earlier on were also based on flu, but also in our setting, the pundits, the ones who were on TV every evening, thought that it was very important to close schools, for instance, because children are a main reservoir for influenza. They can be super spreaders. And if that's true for flu, then it must be true for COVID as well. However, Mark Lipsitch, who I think is one of the foremost infectious disease epidemiologists at Harvard, said very early on, this is in February, before we even had any cases of COVID in our country, he said, flu is clearly driven in part by schools, and we don't understand what goes on with coronavirus in kids, especially this coronavirus. So maybe we should have listened a little more to Mark Lipsitch then, and we can listen to him now because he just wrote a editorial in the New England Journal that came out a couple of days ago advocating reopening schools for young kids. So just to remind you what we know about flu, we know that, as I said, children are a reservoir for influenza. They tend to come to school sick and they get other kids sick, and then their families get sick. And we know that if we close schools for a prolonged period of time, so this is the speed at which schools are closed and the length of time at which they're closed. If we do it early and we do it for a long time, what we can do is abrogate part of the epidemic and actually delay the peak of it. And as we're delaying the peak, then the vaccines can be produced, and we have ways of protecting the population from influenza. So that was the model that everybody thought would be appropriate for COVID, until we start to see the behavior of this epidemic, which is a little bit different from flu. We still don't have really, really great models for empiric data on what school closure actually did. But this is an early study from France showing, taking into account that many people with COVID, and especially children, may be asymptomatic. And so if we close schools, we might delay and abrogate a little bit of the epidemic, but the percentage was actually quite low. Whereas if we keep the parents at home and have them teleworking, we actually have a much greater effect on delaying and actually decreasing the epidemic. So I'm not sure how many people read this early paper or even were listening to this, but that's not what was done all over the world. But because these pundits were so vociferous in their claims that school closure was important and that children may be super spreaders of this disease, it caught my attention because I feared that it wasn't really evidence-based. And so I joined with a bunch of colleagues of mine in an ad hoc group to try and discover what is the role of children in COVID. So we tried to find all the existing literature at the time on what is their role in the illness, what is their role in transmission, what is the role of school closures, and we tried to actually influence policy. And we did that by writing a bunch of position papers. You can see that this one is in Hebrew, came out on the 22nd of April, advocating actually for careful school reopening in Israel, given the facts that we had collected up to that point. So I'm just going to share with you a little bit of those facts, and then show you what happened. So the recommendation from this position paper was to send kids in kindergarten and grades 1 to 3 back to school cautiously, and I'm going to tell you how we got there. So the first bit of evidence was the report of the WHO China Joint Commission, which returned in, I think, late March, early April. And they reported on the data, and they showed that children less than 18 years old had a low attack rate. They only represented 2.4% of all reported cases in China. They weren't able to determine the extent of infection among children, or what role children play in transmission, or whether they're less susceptible. But when they looked at the contact tracing that had been done up to that point in China, they found that children were mainly infected by adults and had not infected the adults. And they actually said that they could not recall any episode in China in which transmission occurred from a child to an adult. And when the vice president of the WHO was asked directly, what do you think the role of children is in COVID? He said, children are a dead end for this disease, which is a very strong statement. And I don't know if he meant virologically, immunologically, or epidemiologically, but that's what he said. And that really perked our attention. So what do we know up to this point? So we know from few population-based surveys that took place in Iceland, in Vaud, Italy, which was the first place of infection in northern Italy, in Geneva, and also in the Netherlands, that the prevalence of COVID infection in children is low relative to the adult population. We know that mortality is extremely low in this age group. And we now have a meta-analysis published in the Lancet. It was pre-publication, but now it's in the full publication. Meta-analysis of 131 studies, almost 8,000 children, and the death rate was 0.09%. It seems to be a little bit higher in the US, but still it's not zero, but it's almost zero. If we look at the first reports from China, this was a study published early on in pediatrics of about 1,000 cases of COVID, of which 418 were confirmed with PCR. On this graph, the different colors are severity of disease. So the purple asymptomatic, the orange mild, et cetera, et cetera. And you have to look with a microscope to find the severe and critical patients among children. So it seemed that even then we could see from the Chinese series, and this is just a very large case series, that children seem to have much milder infection and very rarely have severe and critical disease. And if we look at a study, pooled study from ICUs in the United States, this is an interesting graph because it shows the age of the kids who were admitted to the ICU. And so very few small children, less than between the age of 2 and 12 years. a slightly bigger group, comparatively less than 2 years, and it seems like less than 1 year old children are susceptible to more severe disease, but from the age of 1 to 9, they are not. So we have then a pretty big group of teenagers, 12 to 18 years. And then what happened was there were so few kids who needed the ICU beds in the United States that many of the ICU beds were actually, in the pediatric ICU beds were actually taken up by young adults, 18 to 30 years old, or even people over 30 years old, because those beds were needed for adults and not so necessary for the kids themselves. Having said that, I don't want to discount the fact, and the WHO definitely doesn't want to discount the fact that children are susceptible to this disease. Any age group is susceptible to this disease, and we know of specific complications, the multi-system inflammatory disease, Kawasaki-like disease in children. So I don't want to discount that, but when we talk about policy, I think it is very important to know that children seem to get sick less, and they seem to get less sick. And therefore policy must take that into account. So what happened with SARS-CoV-2 infection in Israel? And these are data up until yesterday, the day before yesterday. It's percentage by age and sex. So the green are females, girls, women, and the blue are boys. So we can see slightly more males than females in almost all age group have been confirmed cases. But if we look at the youngest age group, 0 to 9 years old, there seem to be fewer infections. And what's really important is to know what proportion of the population they represent. So Israel is a very, very young country. We have a huge number of children. We have the classic triangular population pyramid, which doesn't exist in most places anymore in Europe or in the Western world. The population pyramid here has a smaller age group. So you have to add this 0 to 4 and the 5 to 9 here to get to this lower number. And basically what we're seeing in young children between the ages of 0 to 9 is that their rate of COVID infection is half or less than half of their proportion in the population. That's not true for teenagers, and it's definitely not true for people in their 20s. So in Israel, the driving force, I'd say, of the infection is young people in their 20s, but certainly not young children, and not old people. Old people seem to die a lot proportionally of this disease in all countries and in Israel as well. But in terms of the proportion of the population that is infected, it's quite low in the elderly. Having said that, if we look at the entire age group of children, so between the ages of 0 to 17 years, there's no doubt that the infection rate increases by age, remains low until age 9, and then from age 10 and above, it increases and becomes quite similar to older adults. What about COVID transmission in children? This is a big question because, as I said, we started out with the pundits saying this is like the flu, and even if kids are asymptomatic, they're likely to spread the disease and even be super spreaders. So I love the data that comes from the Netherlands. They're so organized, and they present their data so nicely, and they update it every week or so. So they have a page every 10 days or week or so about COVID in children. And this plot is really interesting because it shows the infectors and the infected and their age groups. And you can see that people tend to get infected or infect people of their own age group. So we see this diagonal line, which is highly correlated by age. So 50-year-olds tend to infect 50-year-olds, and 60-year-olds tend to infect 60-year-olds, and et cetera, et cetera. And that seems to be true along all the age groups, except for little kids who are not being infected and are hardly infecting anybody else. So this correlation seems to sort of disappear in the very young age groups. And when they have done extensive epidemiological investigation of household transmission, the source patient has almost never been a child. And not only that, they've done serological surveys, they've done surveys of GP practices and sentinel surveys, and they have found that children play a very minor role in the epidemic. And once they opened their schools, there was no change in the R value. Similarly, in Australia, and actually the paper for this just came out, I think today in Lancet Child and Adolescent Health, an extensive survey of secondary infection in schools in New South Wales in Australia found very, very rare secondary infections. Some children and some teachers came to school sick, but the likelihood of a child infecting other children in the school was very, very small. What about in Israel? So in Israel, as I said, we have a lot of children, and we have, we have households that have many, many children. And one of the great foci of infections in Israel was the city of Bnei Brak, which is a mainly ultra-Orthodox city, very crowded, and many families with multiple children, 9, 10 children, etc. So a survey was done in Bnei Brak to see how often children are infected within the household settings. And this is every age group, every age from 0 to 65. And so you can see this is the 0 to 1 year olds, 1, 2, 3, 4, 5, 6. And again, we see this pattern. Even though someone in the household was infected, the chances of the 1 to 9 year old compared to the other people in the family being infected was lower, considerably lower. In this study from Bnei Brak, they also tried to model what the infectivity of children was. This was much more difficult for them to do, and they didn't have a clear outcome from this study, but the estimate was from this is a hotspot, kind of a heat map of infectability of children. They found that their estimate for small children between the ages of 1 to 10 being infectious to others is about 75 or maybe 80% of what the infectiousness of older children or adults is. So if children are less likely to get the infection and 75 or 80% less likely to spread the infection, that could be the reason why we're seeing much less COVID infection in young children than their proportion in the population. There are some caveats, and one of them is this German study that showed that viral loads, if we look at the range of viral loads in children, this is age 1 to 10, and this is age 11 to 20 compared to the ages of adults. The range of viral load is similar in children and adults, but there were, again, many fewer children in that study who were infected, and there were very few children who had viral loads above the limit that the authors themselves thought were infectious. The other thing about children is that they seem to have a different trajectory of virological, where the virus ends up and where they actually excrete the virus from. So this is the nasopharynx, which is where we usually check. And we can see that children lose their PCR positivity, usually I'd say between 10 to 15 days, it seems to be gone in most children. They also excrete quite a lot of virus in their feces, and we don't know yet if that's infectious or not, but it is one way of monitoring a disease. But we do know in children is that they clear it in their saliva very, very quickly. So if people want to base their screening tests, for instance, on saliva tests, they have to be very, very fast in children because they clear their saliva very, very quickly. Okay, an interesting study from Korea and from South Korea, where they have excellent epidemiological investigation, looked at household transmission in different age groups. And I think that this really put the nail in the coffin of whether teenagers are as risky as adults, and whether teenagers act like children when it comes to COVID, or whether they act like adults. And what they showed was if we look at household contacts of COVID patients, teenagers were just as likely to be infected and to infect others as adults, whereas children, again, between the ages of 0 and 9, were much less likely to. So I think that was a very, very convincing study because it was very well done. Okay, so to conclude this part of my talk, I think that we can easily say that children can get sick. They can also transmit the SARS-CoV-2 virus, but they probably do so less than adults, and they are not, as a group, super spreaders. So let's move to talk about school closures. So at a certain period of time, I think this was early May, this is the world map of school closures. And basically, aside from very, very few countries in the world, most kids in the world were not permitted to go to school, either because of countrywide closures or localized closures, but the vast majority of children in the world were not allowed to go to school. So children not in school, what happens to them? Well, we would like to think that they were busy reading and writing and eating healthy food from their refrigerator at home and interacting nicely with their siblings, but we know that that's not really what happened. First of all, we know that COVID had a huge impact on child nutrition all over the world because millions of children, 364 million children in the world actually rely on school lunches for their one solid meal a day. So if you close the schools, they're not being adequately nourished. But we also know that they're not being adequately educated because online education is very nice for people who are upper middle or high or upper middle class or above, because they have enough computers and they have enough internet, broadband or Wi-Fi, etc. But there's no doubt that within countries and between countries, those who are poor have much less access to online learning, and it's not really an option that's viable on a global scale, and even on a national scale if we don't worry about the children who have less access. And we know that the pandemic has had huge effects on children around the world. We know that there's more domestic abuse, that child poverty is increasing because adult poverty is increasing, that vaccination rates are going down, and that has led the UN to say that while children are not the face of this pandemic, its broader impacts on children risk being catastrophic. And even today, that was reiterated by the WHO, who said that there's going to be a lost generation, especially in low-income countries, of children who have lost out because they're not learning and because they're not eating properly, and for all the social reasons that we know that this epidemic is bringing. So because of all that, and given all this knowledge, we put out this position paper on the 22nd of April, and we recommended school reopening for young children. Young children meaning kindergarten, grades 1, 2, and 3. We said it should be carefully done, combined with social distancing measures. It should not be done in outbreak hotspot areas, which we could identify then in the country. And there might be high-risk groups for whom return was not appropriate. Sorry, We recommend that there be strict hygiene measures, including masks for older children, hand washing, temperatures being taken, that the classes should be split into small groups. I don't know if you know this, but in Israel, we have many, many children. We have very crowded classrooms, up to 40 children in a classroom, and the space, the actual meterage per desk is very low. We recommend that there be physical distancing on the way in and out of schools when adults drop off their kids, and that the guidelines should be developed jointly by education and public health experts. So we circulated this position paper, and it actually had quite a bit of influence both in the media and also with the government. One of the nice things about Israel is that it's a small country, people know one another, and you write something like this, you may be called upon to defend it, and it actually may translate into policy. So this is the nice group of people that we work with, people from infectious diseases, statistics, actually veterinary sciences, but epidemics, family medicine, even geriatrics, epidemiology, public health, demography, pediatrics, and yours truly. And as I said, schools were reopened. I don't know if because of our influence or possibly partly because of our influence. So in early May, the government decided to open schools for the younger children, which we were very happy about. And they were to open in what's called capsules, so small groups of children studying together with a teacher, and physical distancing and masks for children over the age of 7. That was a great idea that actually didn't come to pass. So that was the plan, and then overnight that plan was changed, and it turned out that the government was allowing children from, as I said, kindergarten, grade 1, 2, and 3 to return to school. But in the ultra-Orthodox system, they were allowing children in grades 7, 8, and 9 at the same time to go back to school. And then because of pressure from teachers, children in grades 11 and 12 who had matriculation exams were also allowed to go back to school. So the nice plan of just having capsules of young children didn't actually materialize. And then within 2 weeks, the entire educational system was opened up without any capsules, without any social distancing. And we will see the results of that in a second. You know, one of the results of that was that schools had to be closed because of COVID. And this is one of the schools, so you'll see it soon. This is the Hadassah-Hebrew, one of the largest high schools in Jerusalem, probably the most crowded high school in Jerusalem. And on the wall, it says here, "It's so nice that you came home. We're so happy to see you again." Well, the teachers got to see them again for a very short period of time because eventually the school was closed. They were all sent home, and the only person left in the school was this fumigator or cleaner or whatever. So what didn't happen in Israel is what happened in Denmark. In Denmark, the date of school reopening was set in advance. The type of school reopening, in other words, for which classes, was set in advance. All the parents knew, all the children knew, all the teachers knew exactly what was going to happen. This beautiful infographic was circulated. Everybody knew what their behavior had to be in school. And in Denmark, it worked. In Israel, it didn't work, which we'll see very soon. This is the story of the huge super spreading epidemic in that Gymnasia-Rechavia school. I would call it the infamous school-related outbreak. It's one of the biggest, I think, COVID outbreaks in the world in a single institution. 153 students and 25 teachers. I read today that's 154 and 26. It was published last week by my colleague, Chen Stein Zamir. And what happened in this high school, as I said, was that the government decided overnight that the entire educational system was going to go back to school as usual, without splitting the classrooms, without any special measures in place. Soon after that, within a few days, Israel had a 10-day long heat wave of temperatures above 35 degrees. So you can just imagine class sizes of 34 to 40 children in 40-degree temperature. So the newly appointed health minister took pity on them and said, it's too hot, they're suffocating, they can take off their masks. So now we have 40 children in a classroom with an air conditioner on or with windows closed and all breathing on each other. And as I said, 40-degree weather. And this was the result of this huge outbreak in the Gymnasia school. And it not only was an interesting and important event in itself. By the way, 65% of the students were asymptomatic. None of them got very sick. A few of the teachers got very sick, and there weren't any deaths among the teachers. But this is the epidemic curve in Jerusalem, which suddenly changed as a result of this outbreak in Gymnasia Rechavia, because you can suddenly see this huge rise of cases between the ages of 10 and 19 in Jerusalem due to these middle school and high school children who all got sick at the same time. So how did other countries succeed in reopening schools the way we didn't? In Taiwan, the kids wore masks. They were able to keep their schools open most of the time. They had a very clear policy regarding school closing. If there was a positive case, one case in one class did not merit school closing, but 2 cases in 2 different classes did merit a school closing. That only happened, I think, in 1 school in Taiwan. In Australia, they had gradual reopening of school with a lot of monitoring. In Denmark, as I showed you, they had a lot of planning. So everybody knew what they had to do, a lot of social distancing, and they used a lot of the available space inside and outside of the schools. So a lot of outside learning and even lines on the ground in the schoolyard. And in Holland, a lot of monitoring, physical distancing for the older children and not for the younger children. And all of these countries successfully were able to open schools and finish the school year. And in Australia, right now they're having a second wave in some places. So some places schools are closed and some places they're not. An interesting study from Finland and Sweden compared the 2 countries. So Finland and Sweden are right next door to each other, very different policies regarding COVID. Sweden kept their schools open for preschool and primary school. And Finland closed their school as between week 12 and week 20. But when they actually went to look at the incidence of COVID infection in children and in children in these 2 countries, it was identical. So keeping the schools open did not change the infection rate. The reason that it changed here at the end of the survey was because they changed their testing policy in Sweden. Interestingly, also teachers in Sweden did not get sick more than the rest of the population. So the relative risk for teachers as a profession compared to others was 1. So I think those are important lessons to be learned. So a lot of people think that the second wave of COVID in Israel was caused by school reopening. And, you know, on the face of it, that's what people saw. They saw that schools opened and then we had this huge second wave of infection. But if we take a closer look at it, at what actually happened in Israel, it's a lot more complicated than that. So in this graph, which I agree is very, very busy, but I think it tells a very good story. So the blue line is the rolling 3-day average of confirmed COVID cases. in Israel. So this is what our epidemic looks like. This is the first wave. This is the semi-contained containment period. And this is the beginning of the second wave. And now we're way up here because that was 1,000 cases a day. In the last few weeks, we were closer to 2,000 cases a day. So we can see here with the red flags, the measures that were taken to limit the epidemic. So we have decreasing gatherings, first for 5,000 people, then later for 100 people, border closing, school closing, and non-essential business closing until actual lockdown on the 25th of March. And then you can see what happened to the epidemic. It starts to decrease and the government decides to ease the lockdown. And so we have opening of street shops, then we have opening of all the stores, and we have partial school reopening, what I showed you before, the small children, the ultra-Orthodox grade 7, 8, and 9, and the matriculating high school students grade 11 and 12. Then we open the supermarkets and the malls, and then soon after that, we open all the schools. So it wasn't just that we opened schools, we basically did everything very, very, very quickly. We continued with the green flags, opening restaurants and bars, opening wedding halls to up to 250 people. But you can see that we start to do these easing of lockdown when the epidemic was already, the second wave was already starting to take place. And then we have this very unusual situation where we have green flags and red flags at the same time. So at the same time that people are noticing that the second wave might be starting, we open cultural venues, which were quickly closed after that. But these three steps, as well as this one, were probably just as important in causing the second wave as the general opening of the schools. Because what happened is when people start to go to markets and malls and to restaurants and bars and to go to weddings, especially when there is intergenerational transmission and dancing and singing and indoor yelling and screaming and things like that, is that you have a huge increase in the community spread of the disease, and that's going to be reflected in the schools. The schools are not cut off from the community, and the community is not cut off from the schools, and we're going to see that reflected in COVID in children. We actually looked at speed of lockdown, comparing Austria and Israel, because they're two countries that have very similar populations. Austria has twice as many people over the age of 65 than Israel, and that's reflected in their mortality rate, which is twice as high as ours. But the size of the population and the speed of the lockdown was very similar. We did our own stringency index of only four elements. So limiting movement, business closures, school closures, and limiting assemblies or groups. And we can see that the lockdown speed was similar between Israel and Austria. That's in the blue graph. The red graph is the actual morbidity from COVID. But what is different is the speed at which the easing of the lockdown took place. So in Israel, it was over only 39 days, and in Austria, 50 days, and they have not experienced the second wave like we have. So getting to near the end, what are the lessons learned? And I've tried to really combine two aspects here, children and Israel's policies and their effect. So I think we can say that early restrictive measures and the lockdown did decrease, but did not abolish the virus in the community. This happened at tremendous social and especially economic cost. The easing of lockdown measures was hasty and should be done gradually. I know that this is being debated right now in the UK, and it has to be done with monitoring. I didn't have time to get into this, but political pressure does cloud decision-making. And for instance, the decision to send ultra-Orthodox children of grades 7, 8, and 9 back to school at the same time that we sent the kindergarten grades 1, 2, 3, I think is a mistake. Those children are at much higher risk, both to get the infection and to transmit the infection. And I think that we can't help but note the low mortality rates in Israel, and I think that has to do with demography and also excellent medical care, which has kept the death rates low. Regarding children, I still think that children age 1 to 9 are at low risk for severe disease, complication, or death, and that should dictate our policy. Children should not be made to suffer because they are not the ones who get sick with the disease. I think that we have to go out of our way to make their lives better and to ensure their futures. Children at all ages are at high risk of suffering the social and economic consequences of COVID. I think that's clear all over the world. I do believe that school opening is feasible, but it has to be done carefully and with monitoring and in areas and periods of low community transmission. So if we see that the rates in the community are going up, then we know that that's going to be reflected in the schools. At a certain point, there were, I think, 250 schools closed in Israel and 22,000 children not in school after they were reopened because of 1 or 2 cases in the school. So I'm leaving with this flashing light because we're supposed to be a light unto the nation. But I fear that we're kind of a cautionary tale unto the nation. So we should be a flashing light unto the nations. There is something to be learned from the way Israel has handled this COVID epidemic. And as I said at the beginning, there's something not to be learned from the way we've handled this epidemic. And just one final thing, I think we still have many unanswered questions. And one of the most common one is should children be in contact with grandparents? What is the risk to grandparents from children? And I think we really don't know the answer yet. We know that children can have the disease. They have the same viral load. They're less likely to be sick, but can they infect their grandparents? Probably yes, but probably less than their teenage siblings. So I think that's enough for now, and I'm happy to take questions. Thank you.
Thank you very much, Ora, for a very, very interesting and very comprehensive view of the Israeli situation and as well as its comparators. The one question that has come up already is the question about the differences in mortality, the differences in huge differences in mortality. If you take you take the situation, more Jews have died in Britain. In fact, 10 times more Jews have died in Britain, more or less, than have died in Israel. And it's an extraordinary figure. Do you have any comments, or has there been any discussion about that in Israel?
Yeah, so first of all, I think that demography does play a big role. So we have many, many fewer people over the age of 65 than you do in Britain and even in the Jewish community. So that's the first thing. The second thing is if we look at the super spreading events in both countries and in other countries as well, they're probably very similar. So we have Purim, we have Pesach, we have funerals, we have weddings. Those events were as likely to be events that spread COVID than in Britain as well as in Israel. In terms of mortality, I think that we were never overwhelmed, so we never had to triage. we don't have a lot of ICU beds. We have, I think, about 2,000, something like that. But interestingly, in Israel, because there's always been a bed shortage and there's always been a ICU shortage, many of the internal medicine wards are very well trained and equipped to take care of ventilated patients. So that we don't rely on the ICU team necessarily to take care of ventilated patients. I think that was really relevant in the first wave. In the second wave, it's much less relevant because there are many fewer people on ventilators now. Of all the, as I said, we've had almost 2,000 cases a day in all of July, which is a huge amount of transmission. We have about 700 people admitted to hospital right now, of whom hovering around 100 each day, between 97 and 104 each day are on ventilators. So the clinical practice has changed. The ease and the speed at which people are put on ventilators has been decreased. The protocols seem to be much more efficient. We have maybe the UK to thank for the dexamethasone study, but I don't think that's the only factor. I think there's been a learning curve. Why mortality among Jews was so much higher in the UK than in Israel. I think things happen slower in the UK. My experience is than in Israel. Israelis act fast, and it's possible that they just moved faster when people were sick. And as I said, they weren't overwhelmed. So they were able to take care of the sick people who came in. I like to say sunshine, fresh air, but I don't think that would affect mortality. That would affect the number of people getting sick.
The other question that highlights in the study is that the infection rate is in the 10 to 19 age group appears to be higher than it is in the UK. Is this a social phenomenon, or is it and how does it relate to things like the starting of military service and that kind of thing? Have there been cases, for example, in recent army recruits?
Mm-hmm. Okay, so I think the biggest age group, the age group that proportionally has the largest number of cases is the 20 to 29, which includes some of the people in the military, but mostly people just after the military. I think that probably reflects the amount of social contacts that they have. So these are very social people, and they're possibly working during the day and then socializing at night. And that's why we're seeing more infection. Also, the yeshiva students, the young yeshiva students are in that age group, and they're studying in very, very crowded conditions. I heard about a yeshiva in Jerusalem this week that has over 50 cases. So I think that transmission in very close quarters there. In terms of the army was in lockdown when the civilian population was in lockdown too. So soldiers didn't go home, and they stayed in their bases, and they were able to more or less control the spread during the first wave. In the second wave, the number of cases went up in the army, but they have very good epidemiological investigation there. And it hasn't been out of control. The youngest person to die in Israel was a 19-year-old who was a young woman with multiple developmental abnormalities and respiratory problems, pulmonary hypertension. After that, there was I think a 29-year-old who had a malignancy, and a small smattering in their 30s. So we've had very few deaths of people less than 45. And I see that there is question here about Kawasaki. Okay, this is not my expertise, but I'll just try and answer that question. What is known of why certain children are susceptible to Kawasaki? I know in Britain, the early studies showed that they tended to, and also in France, they tend to be more African or Caribbean origin. We've had a few cases of Kawasaki, like inflammatory syndrome in Israel. They were not in Africans. They happened in the winter. I haven't heard of cases, maybe one or two in the second wave. So I wonder if it's co-infection with other respiratory viruses, because we know that Kawasaki is related to respiratory viruses besides coronaviruses. Why are some more susceptible? I don't know. But in Kawasaki, also this syndrome, if you treat it quickly with IVIG and other treatments, it should be controllable. We have not had any deaths from the Kawasaki-like syndrome in Israel.
The one question is obviously we're asked is about the comparators between the Arab population and the Jewish population. Have you any data or information about that?
Well, we have information from localities. So in the first wave, we had two interesting outbreaks. One was an outbreak in an Arab town in northern Israel. And it seemed to be that the index case for this outbreak was a mashgiach, a supervisor for the meat plant. There's a big meat plant in this town. So actually it was a Jewish man who brought the COVID virus into this town, and many people worked in this meat plant, and the virus spread from there. The second was an outbreak in a Bedouin town in the south, in Hura, and this was quite a large outbreak, and it turned out that it had to do with a wedding, and many people came to this wedding and then spread out to different villages in the Negev. So I think we're talking about social situations. Right now, there's quite a large outbreak in East Jerusalem. The infection rate is increasing in the West Bank and the Palestinian populations, which were relatively spared at the beginning. And we have some Bedouin towns. We just had this holiday, this feast, Eid al-Adha. So we're seeing some increased infections after this holiday. So I think it has to do with social events and lack of physical and social distancing, and non-adherence to mask wearing. Mask wearing is it's by law in Israel, and you can get quite a heavy fine for not wearing a mask. But still, I think social mores and norms are more important than the fines, and they haven't dug in every community.
There's a question that's come up about healthcare workers. I don't know whether you can see that. Do you have any comments about the question about the lower morbidity and mortality among healthcare workers in Israel than in the UK?
Right. So I think that's fortunate. Probably, I don't think we ever had a PPE shortage. Not that I know of it. So I think that as soon as we knew that people were able to be protected, and separation from positive patients pretty early on, we had the hot and the cold emergency rooms. We had separate wards, and pretty good PPE for the healthcare workers. In my hospital in Hadassah, there's also been a huge amount of testing of workers. So Hadassah decided early on that it's going to use some of its resources and expertise. This is actually much to the dismay of the health ministry who didn't like this this program. But so they actually had, I wouldn't call it screening, but it's kind of a loose screening program for healthcare workers. So I personally have been tested 4 or 5 times, but not because I have symptoms, just because I was called to get tested. And so I think that's not a bad way of case finding among healthcare workers and removing them from the healthcare settings. Many of the healthcare workers who have gotten sick in Israel have gotten sick from social encounters and not from the healthcare setting itself. And fortunately, we've had some very serious illness among healthcare workers, but I don't think that we've had any deaths. Yeah, so that's fortunate. I think that the PPE is super important, but I think testing is also important.
You mentioning testing. I mean, what is the position about testing, the methods used, and the speed of access and the speed of reporting, which is one of the things that's discussed very widely here?
Okay, so at the beginning, there seemed to be a lot of resistance in the health ministry for making testing widely available. They had very, very strict criteria for testing, and it mainly had to do with contacts from abroad or returning from abroad. So a lot of symptomatic people were not tested during the first wave, and that probably means that the first wave was probably much bigger than what we actually knew. And then testing got ramped up in terms of the infrastructure, the facilities, and we were able to do between 20 and 30,000 tests per day. I actually have a slide of it that I didn't show, so 1 second. Let's see if I can show it to you. I thought that you might ask about testing. Okay, so this is Israel tests per 1,000 people, and this is the UK tests per 1,000 people. So since April, we've been much higher than the UK, and now even higher. So we've ramped up to, as I said, 20 to 30,000 tests per day. But we have very high positivity rate now in Israel because we have so much community spread. So we have around 8% positivity rate for our tests. I'm not answering your question in a very systematic way. So let's think. So testing was very strictly controlled at the very beginning. It had to do with a strict set of symptoms, which didn't reflect all the COVID symptoms. And it had to do with contacts from abroad or coming from abroad. And therefore, many people were left out of the testing. Then they added anosmia and loss of taste to the criteria. That added more tests. When this big outbreak happened in the Gymnasia school, there was a huge pressure to test all of the kids. And once they tested all of the kids, and a lot of their family members also got tested. And that's really when you can see here that this kind of, the number of tests per 1,000 started to increase because the criteria started to loosen up. The other thing was that testing at the beginning was centralized. It was the MDA, like our Red Cross, Magen David Adom, that did the testing, and the Ministry of Health controlled it. And then eventually it was released to the health maintenance organization who actually give the primary care in this country. And so they were able to use their own criteria. Right now we have testing that takes place in, I think, over 30 facilities in Israel. So in the HMOs, in all the hospitals, and a company called MyHeritage, which is one of those, genetic companies that you scrape your buccal mucosa and check your genome. They actually set up a PCR lab for COVID testing, and they are supposed to be getting up to 10,000 tests a day. Up until now, they've been doing the systematic testing of nursing homes. That's something I didn't talk about. You've had a huge problem of mortality and morbidity in care homes. We've had a much smaller problem, but care homes were also a focus of mortality. I think about 1/3 of our deaths were from care homes, and that started, spurred a program called protecting our mothers and fathers. And part of this program called Protecting Our Mothers and Fathers was actually doing systematic testing in this care home. And the company that was charged with doing this test is MyHeritage. So it's this genetics company. So it's like a private public partnership with the government to test the care home population.
Are the care home workers also being tested?
Yeah, so what they decided now is they just stopped, because the amount of infection, the prevalence was very low among the residents of the care homes. It really wasn't effective and definitely not cost effective, but they decided to do systematic testing of the workers. And that's what they're doing now. And the workers are like the sentinel for the care home, because it turns out that most of the infection came from outside, which makes sense. So there is systematic testing of the workers in the care homes.
Would you like to see, at the end of the day, elimination of the virus, near elimination, immune response? How would you like the Israeli objective to be?
You know what? That's a very good question. That's one of the frustrations that I've had as a citizen and also as an epidemiologist, is that the strategy was never 100% clear to us. So the lockdown strategy was extremely effective, as you saw, but it probably was too long. And we probably could have had a much more gradual, but even earlier release measures, and then we wouldn't have had the tremendous economic and social effects of this crisis that we're seeing now. But ironically, we almost got to containment. I mean, less than 20 cases a day in the whole country. Probably with a little more effort, we could have looked like New Zealand. But those 20 cases were probably hiding 200 or 2,000 cases in the community that we didn't know about. And as soon as these release measures came in full force, including opening wedding halls and cultural events, then we saw this sort of full force of this second wave. So what are the goals? I think every country has the same goals, is that to try and decrease morbidity and mortality until hopefully a vaccine comes along. In Israel, I think that we also have to have a really good strategy for improving the social consequences of this epidemic, because we are in chaos right now. I don't know if you know, but we have a huge amount of demonstrations. We have political chaos in the government. We have a lot of lack of trust. So that if the government does decide wants to come down hard and have another lockdown, I predict that there will be a lot of pushback from the general population and pockets in the population. So the ultra-Orthodox population feels that they've been singled out because there have been quite a few outbreaks, and even now outbreaks in cities with large ultra-Orthodox population. So there is a lot of unhappiness and bitterness and resentment out on the street, and that's part and parcel. I don't think we can just look at the virus as a microbiological entity. We have to look at this crisis as a social crisis as well.
I think we've kept you going till 11:15 Israel time, which is really way beyond the call of duty. So I wanted to say thank you very much for a remarkable coverage of a complicated and fascinating and also very, very disturbing area. So thank you very much. And
thank you.
Look forward to hearing more about it at a later stage.
Okay, thank you, and good luck in the UK.
Thank you.